This module focuses on understanding muscle weakness and relevant interventions to treat strength deficits in people with MS. Weakness is defined as a decrease in muscle strength. Individuals with MS are weaker than controls even when adjustments for age, body mass, and fat-free mass were made. Weakness in MS can be classified as primary and/or secondary. Primary weakness is the result of altered central motor drive, delayed neural transmission, and altered metabolism or mechanics that result directly based on the location of the lesions. Secondary weakness occurs as a result of the deconditioning and disuse associated with progressive disability. Muscle weakness has been correlated to increased falls, slower walking speed, decreased activity tolerance, and poor postural control. Muscle weakness can also be a predictor of ambulatory function in individuals with MS. Progressive resistance training has been shown to improve lower extremity muscle strength in numerous studies. Not only does strength increase, but muscle hypertrophy and motor unit adaptations have been shown to explain the physiologic mechanisms that affect functional change. However, strength gains are probably isolated to muscles trained. Most research studies performed progressive resistance training 2 times per week for over 2 months and target major lower extremity muscle groups. Home exercise programs have statistically improved leg strength and should be used for people with MS. Fewer studies have measured the effect of resistance training on muscle endurance, but these studies suggest that progressive resistance training also positively impacts muscle endurance and motor fatigue in people with MS. Training capacity in both upper and lower extremities increases up to 45% with resistance training in people with MS. So increasing loads as training progresses will allow patients to maximize their potential for strength gains. One final study looking at resistance training for people with MS found significant improvements in knee extension and ankle plantar flexion strength, but non-significant changes to knee flexion and ankle dorsiflexion. Muscle volume and cross-sectional area were also non-significant. The results are mixed regarding the potential for improvements in knee flexion with strength training. It's possible that higher training loads for knee flexors and dorsiflexors are needed to see significant changes, or spasticity and other confounding factors might prevent the strength gains from being appropriately assessed. Eccentric training improves strength in many patient populations more effectively than other forms of training, but this doesn't seem to be the case for individuals with MS. One study did not find significant changes in strength between concentric and eccentric exercise, but it did find that individuals' abilities to perform balance activities and ascend stairs were worse after eccentric exercise compared to concentric resistance training. Another small study found positive effects of isokinetic eccentric training of the quads and hamstrings, but there was no control group in this study. One final study, looking at differences in muscle strength between people with MS and controls, found that concentric quadriceps muscle force was significantly lower in people with MS. People with MS have a harder time maintaining muscle force during increased speed of movements, so concentric strengthening programs at higher velocities may be the most effective to target MS strength deficits. Since pulmonary function can be affected in individuals with MS, especially for those with more advanced disability, respiratory muscle training is a form of strength training that can positively affect respiratory muscle weakness. One study found significant increases in respiratory muscles with expiratory muscle strength training. Maximum voluntary cough, a functional measure of respiratory muscle strength, may only increase in individuals with moderate to severe disability. Another study that involved a home exercise program with respiratory muscle strengthening did not directly measure improvements in respiratory muscle strength, but found increased maximum expiratory pressure and forced vital capacity, measures that suggest improved muscle control to increase expiration abilities. Gait endurance also increased with respiratory muscle training. Though research is limited, it seems that respiratory muscle training can improve strength in individuals with MS. Aerobic training is a less common intervention used to improve strength in individuals with MS, but a few studies have identified potential for strength gains using aerobic exercise. Robot-assisted gait training and body weight support treadmill training Both improved lower extremity muscle strength, although the effects might not be clinically meaningful. One study found that combined aerobic and strength training increased muscle endurance in women with MS, but not men. Although these studies use strength as secondary or tertiary outcome measures, it seems that gait training might not be as beneficial as strength training to target muscle weakness. Vibration therapy is a relatively new intervention that has been evaluated in the literature to determine its potential effects on muscle strength. Whole body vibration uses low amplitude, low frequency mechanical stimulation to exercise muscle. Studies suggest that whole body vibration can significantly improve muscle strength, but better quality studies need to be done to really understand the influence of vibration therapy on muscle strength and function. A few other studies in the literature have examined the effects of different interventions on muscle strength deficits. One study found that electrical stimulation and progressive resistance training improved strength more than the control group, but no more than the group that only did progressive resistance training. Another study found high voltage pulse galvanic stimulation increased knee flexion and ankle dorsiflexure strength. Ampera is a medication that's indicated to increase walking speed in MS, but it has shown increases in lower extremity muscle strength. Although strength gains appear non-significant, they may be greater when individuals with MS are stratified into responder versus non-responder groups. Finally, aquatic therapy may promote increased muscle strength in people with MS. One study only evaluated improvements in grip strength, and another study found increased knee extension force despite no changes in knee flexion strength. All of these studies show some, but maybe not significant, improvements in muscle strength for people with MS. The most well-researched intervention for muscle weakness is progressive resistance training, including concentric exercises and respiratory muscle training. Vibration therapy may be a promising intervention in the future if better studies can validate its use. Aerobic training, aquatic therapy, electrical stimulation, and Ampera might be exercises or interventions worth considering depending on an individual's unique presentation of symptoms, although they are probably not the best treatments to address muscle weakness. This concludes the module on interventions to target muscle weakness in individuals with MS. Please proceed to the module post-test and continue to explore other modules that interest you.